We're live. Go ahead.
Live. All right. All right. Well, thanks for being on the call. What I wanted to go over today is just talk about just posture a little bit more. I know we've talked a little bit about posture during some of the lunch and learns of the last 2 weeks. Definitely some postural control stuff, things like that. So we can talk a little bit more just about what efficient posture is, how to assess more like static postural position and thing, and then go over just some different breathing exercises that we can incorporate into our programs and see how it really ties into posture and quick changes that you can make. Also really want to talk about it too, because right before all this craziness started, I had taken a course that incorporated some of this breathing, some breathing techniques and postural changes and how it kind of relates to lifting. So I think by doing the lecture, it kind of helps me make sense of the course a little bit more and how to really tie it in and incorporate it into what I do and what you guys do in terms of the training aspect. So just real quick, just kind of the approaches that I'm getting a lot of my information from, the FMT approach, the functional manual therapy. And just put it up here, kind of our pillars that we look at as verification that I have. And really, I mean, it's very similar to what you guys do and the trainers do in the gym. So we look at 3 different approaches. Our mechanical capacity, it's looking at some joint tissue, some soft tissue, any restrictions that you might have that might limit positions or prevent you from doing certain movements. Looking at a neuromuscular function, that kind of ties into are the right muscles, the right things firing at the right time. Can you maintain a stable base of control as you start to move around it? And then starting to incorporate all that into our motor control issues. And I think we've talked a lot about the motor control the last 2 weeks and how it kind of ties into what we do. So those are kind of the 3 pillars that we do. And I think it ties in really well to what you guys do in the gym in terms of the FMS approach. It's really similar. So, I mean, there's not much of a difference there in terms of rehab and training. It's all the same thing. It's just kind of like where we're getting our clients on those 3 phases. And the course that I just mentioned that I took a couple months ago was the Human Matrix course by a guy named Zach Couples. I think a lot of the information from that course was from the Postural Restoration Institute, PRI. And when I was doing my fellowship program with the IPA in Manhattan, I got to work with Ron Hushka a little bit. He would actually come into New York and treat some clients. So I got introduced to the PRI principles and things from him. So really just working on tying some of these things together in what I do from a functional therapy approach and what you guys do in the training aspect from the FMS approach. I think they all tie together pretty well. So it's really just the goal of what I'm talking about today. So just getting into it, correcting posture. So put in here, your posture is not terrible. If you have a client and you mention the word posture, every single client without fail is going to tell you their posture is terrible. It goes without fail. Like you say, oh, work on some posture things. Everybody says, oh my God, my posture's terrible. Not terrible. There are some people with terrible posture, but we don't really see them too often. But there are definitely some things we want to look at and things we can change that are going to make you a little more efficient, probably make you a little bit stronger and probably keep you a little healthier as you're in the gym or you're going through your programs a little bit more. So we have here, in just terms of our static assessment. So I know that we, yesterday we were talking about in our call, we talked about our kettlebell carries and things. If it was true postural issue, control issue, what are we doing? Like, what are our go-tos to correct it? Kind of taking a step back from that and even just looking at static assessments before we even get into like movement and how we control posture. We can really classify people into 5 different categories of posture. And so what the ideal posture that we'd want to be in is the one all the way to the far right, right over here. And we classify this posture as a vertical. And so 2 things we're looking at pelvis and we're looking at the thorax. And we want to see the thorax directly over the pelvis in a stacked position without any like bend, forward bend or backwards bend. So you can see kind of here, we draw those lines and those arrows in. Those lines are right on top of each other. Ideally, that's where we want to get most of our clients to be. That's where they're going to be most solid in that position. They're going to have less compensations, probably be strongest in that position. But a lot of people don't get into that. So what we'll see when people come in is either one of these like 4 other positions here. And so if we're going all the way to the left, what we would do is we classify this person as a vertical posterior. So the thorax is directly over the pelvis, but there's a little bit of a backwards bend. And you can see from that line there, there's a little bit of a tilt back where the sternum's elevated, thoracic spine's backward bent. And some common conversations we see there is we start to see like it creates like different stress points, things like that, especially at like the TL junction here. We can throw the posture off a little bit, okay? I think the next two postures are really the most common ones that we see. And so we classify this next one here, the second one, as a posterior. So the thorax here is behind the pelvis, so it's posterior to the pelvis, so there's a posterior component there, and it has that backwards tilt. So you're starting to get a lot of just different stresses through here. This is what we see a lot with our younger female athletes, I think, that come in. Really common there. They come in with that big lordosis, like elevated chest through here, or even some people like growing up, like your parents would yell at you to sit up straight. First thing you do is go right into that position there. Mm-hmm. And it's almost like your military posture. So a really common conversation that we see there. Now, ideally what we want to do is get it more into a vertical position by kind of bringing the thorax forward and stacking it on top of the pelvis there. The third one here, probably this, I don't know if this one is the most common or the second one we just talked about, but this is our cell phone, video game, computer posture that we see with a lot of people today. This is what we classify as a posterior anterior. The thorax is posterior to the pelvis, so there's our posterior component, but we have that forward tilt with the sternum's depressed down, leads more into that forward head positioning, and really just like poor diaphragms. And this is what we see. A lot of people, just the way that you position yourself. If you work at a desk most of the day, you're on your cell phone, most people kind of looking down like this. This is what we can start to develop into. And then the fourth one, a little less common. We do see it every now and then. But this would be an anterior posterior. So our thorax is anterior to the pelvis and we're tilted backwards over it. So it's almost like we see this in older populations. People tend to lean forward. It almost feels like their legs are trying to catch up to their upper trunk. But really, find out these are like the 5 main classification systems that we can use to identify where some postural dysfunctions might be and how do we correct it. And always the goal is to try to get to this vertical position as quickly as possible. And that would be like we were talking about yesterday with the kettlebell carries, things like that. If you can get somebody into this position, they're probably going to be able to carry that kettlebell a lot longer and probably heavier weights too, versus some of these other positions where they might start to give out a little bit quicker. And so it's one thing to know what static position you're in, but how do we fix posture? And so what I was mentioning before is stacking, right? So we're going to stack the thorax over the pelvis. So that's always the goal, is to get into vertical alignment with your rib cage directly over your pelvis. Now, ways to do that, I think the best way, obviously, is as a manual therapist. I think the quickest way is to really get a good assessment on somebody and figure out what's driving their position that they're in. So you have somebody who's in a backwards bent position like that. It could be the main driver of the issue, could be coming from the hips, could be coming from the rib cage itself, but really just getting in there and trying to figure out where their dysfunctions are coming from, and then giving more specific corrective exercises to work on that is going to allow them to get into a better stack position pretty quickly. And then a lot of just different corrective exercises we could use with breathing exercise. So it's kind of where we're going now, is some of the breathing exercises that I started learning through this course that I took. And it makes pretty good changes. Like, you're able to get that thorax stacked over the pelvis pretty quickly. The only thing I know, at least clinically, what I've noticed is exercise alone a lot of times don't create long lasting changes, but I think they're important, like on a per session basis. So like by getting yourself into a good position, I think you'll be able to kind of do each lift, but I haven't seen that it really carries over that well. But I think combining a lot of the things that we do would tend to make more of that longer lasting change. So to really decide on how to get a little bit more specific with these breathing exercises and some things that we can do, really just a quick assessment. And I think this is something I could do, but I think any of the trainers can do this too if somebody came in as part of like the FMS screen, things like that. Really, it's just we want to look at sternal angle. And so first position here is hands right on the lower border of the xiphoid process. Come down, just kind of feel where the ribs are. You're going to have 2 options, right? So you're going to have a narrow angle here, so you can see the hands are pretty close together, and increase that narrow angle at the sternum, or you're going to be wide. It's really just one of the 2. again, there's compensations, there's different compensations here and there, but for the most part, this is what you're going to see. Now, what these angles are, these are coming from the lower border of the ribs. Now, with that, these are compensatory movements for the most part. So when we have a narrow angle, it's more of a compensation from what's happening up above. And so if I have an inhaled axial skeleton where I'm a little bit wider anterior to posterior up here, in order to get air in and out, my lower ribs are going to start to narrow a little bit more to really force that air out. So it's more of a compensatory movement. Vice versa. So now, then if I have a wide angle, I'm in a more exhaled position. So I'm kind of in here. There's less of that diameter anterior to posterior. And then the lower border of the ribs need to try to get air in and out of the lungs. So they're going to start to get a little bit wider and going to expand a little bit more laterally. And that's just what's creating the change in the ribs there. Generally, what happens from up above happens down below. So what we're going to look at too is the infrapubic angle. That's not something you're going to assess. You're not going to put your hands anywhere near there. But if you have a wide or narrow infrasternal angle, it's going to be the same thing at your infrapubic angle. And we just want to know that too, because what we're going to add in is we're going to decide if we want to add in like any sort of adductor facilitation or abductor facilitation. So if we have a narrow infrasternal angle, we're going to be narrow at the infrapubic angle. To make it wider, we're going to add in an adductor squeeze. And so I think this is some of the things that I found helpful with this course, is getting a little more specific. I just always used to go to like TheraBand around the legs, push out into the band, everything's abductor. But a lot of times just adding some of these changes here with adductor squeeze, things like that can make a difference in our mechanics with breathing, but it also translates over well into some of the bigger lifts that we do. And then the last thing we want to look at is more of the upper ribs and what are we doing with our arms. So adding in a reach is going to kind of be like the last component to what we're adding in, but the reach is also going to help facilitate what we want to happen at the ribs for the breathing exercises to keep everything stacked. And so we're going to come back to this, but what we have here is with the scapula and humerus, anything from 0 to 60 degrees with shoulder flexion. So this motion here, if you're below 0 to 60 degrees, it's going to facilitate posterior expansion of the upper ribs. If you start to work your way up, it's about 60 to 120. So and from here to about there, it's going to facilitate more of our anterior sternum here. It's important to know, so if you have somebody who's in this position where they're collapsed down, they're not breathing in anteriorly, you're going to want to put the arms up into this position to start to get that sternum to lift. And then anything from 120 to 180 is going to facilitate both. So you're going to start to get that anterior posterior motion. You're probably going to get like the most bang for your buck getting into this position. The only issue with this is, especially starting off, it's hard to maintain a stacked position with your thorax over the pelvis if you start reaching up overhead. Because a lot of times you start to see that tilt. A lot of people won't be able to keep this position as you reach your arm up overhead. So we generally start with either one of these to start to work up overhead. Now, with our specific breathing exercises, so with a wide angle, so we saw there, we have that wide angle there. So if we're wide, what we want to do is we want to facilitate those ribs to drop down and in. So here, we're going to do a silent inhale through the nose. You're going to do a pursed lip exhale, so like you're blowing out candles until you get all that air out, and really trying to get those lower borders of the ribs to drop down and in. And then you're going to pause before taking your next breath. With that, before the next breath, though, you want to maintain your abdominal tension before you breathe in. So you're really keeping those ribs locked in and down. You breathe in, expanding up above, and then repeating that process for about 3 to 5 breaths. You do that on both sides. If you're a narrow angle, you're going to do a same thing, silent inhale through the nose. The only difference here is we want to create less resistance through our whole system and get to not really facilitate some of those deeper trunk muscles. So when you exhale here, it's going to be like you're fogging a mirror. So it's going to be more of a versus the, because that, again, that pursed lip is going to facilitate some of these deeper trunk muscles to kick in. It's going to get those lower ribs to drop, where this exhale is just going to allow more of a relaxation and less resistance approach to it. But you're going to go through the same thing. So you're going to have the exhale, 3 to 5 second pause, inhale, like we talked about above. For both wide and narrow angles, we're going to try to facilitate a posterior pelvic tilt first. And I think kind of for most people, a lot of people live in that anterior position there. that posterior pelvic tilt is going to be pretty important. We're going to try to always facilitate a posterior pelvic tilt with glutes and hamstrings, right? So that's why like a lot of things that you guys are always doing in terms of dynamic warm-up correctives, a lot of bridging, things along those lines. That glute hamstring is super important to get that posterior pelvic tilt. A couple of there's going to be some different corrections here and there that you can work on to make sure you get in the right position, but for the most part, it's always posterior. Now, in order to really get into like the lateral border of the ribs, we're going to go more into a sideline position. So most angles that are wide, we want to get those ribs to drop down. We're going to go into that sideline position because it's going to facilitate that lateral border more. We're going to go into more of a supine position if we want to kind of get away from that lateral border of the ribs and work more from up above in that anterior posterior expansion. So that we do more in a supine position. And then so I just put in here some different examples of what that setup would look like. And so this sideline position would be more for like a wide angle here. We're setting up the head here, and this top arm is pushing into the ground, just facilitate the trunk a little bit more. Put a ball between the legs, but we're not squeezing the ball there. That's just really setting the position. If you wanted to, you could put a band around the knees to facilitate the abductors. Heels are pushing into the wall, again, to get that hamstring glute to fire, and it's creating more of that posterior pelvic tilt. And then it's really just breathing into the lateral border of the ribs. Exhale, let the ribs drop down, maintain tension for the next breath. Picture over here is more that supine position, and you can see here a little bit of that posterior pelvic tilt, but he's starting to lift off the ground. And sometimes when I was playing around with this too, like if you posterior pelvic tilt, you're actually going to see some people like lift their stomachs up towards the ceiling. Whereas if you add a little bit of bridge in, or like you let your knees go straight up towards the ceiling, it actually facilitates more of that posterior tilt, and you can get a better stack of the thorax and the pelvis here. Legs are doing the same thing though. So feet are up against the wall, pushing the heels down and pushing into the wall. Again, hamstring glutes facilitating that posterior pelvic tilt. You can't really see it here, but there's a ball between the legs. Here's where you want to create that adductor squeeze, and that's going to help kind of facilitate there a little bit more. The only thing not shown in the pictures here too is the last thing we do is add in a reach. And so the reach, again, is specific to each person. So if I'm limited anteriorly, posteriorly, it's gonna change my position where I put my arms. So if he was really limited into the posterior aspect of the ribs, maybe having the arms like down below at the side here, reaching up towards the ceiling. If he was limited anteriorly, so it might start to work up towards like 90 degrees at a reach in. If he could maintain a good stack position here, start to get more benefit by starting to reach up overhead. And again, so that reach touch the ceiling, but you can start to add weight in, you can add resistance in too, while maintaining that breath there. Now, the thing I like with these breathing exercises, and what I was saying before, is when I've given breathing exercises in terms of like home programs, or I know we've given to some athletes to do when they're at in terms of the breathing, I think a lot of times it goes overlooked. Maybe it doesn't get done quite as much because it's kind of just like, all right, just breathing. I can do that whenever. But if you get these really specific, this can carry over well to somebody who's having difficulty doing like one of their major movements, whether it be a squat, deadlift, the hinge. You can put them in these positions, and a lot of times it cleans up some dysfunctions that they might have, right? So if I had somebody who was having a hard time with the squat and they were more of a narrow angle that we just saw before, so this was the person on their back. What we could do if they're having a hard time with the squat is basically do the same thing in standing. So elevating the heels, because doing that posterior pelvic tilt it's gonna change the orientation of the hip and pelvis. So elevating the heels is gonna make the movement a little bit easier. But add in a ball squeeze in to get that adductors firing to make things a little bit wider. And then you change the position of your arms. So say that same person has a hard time breathing posteriorly. Instead of just holding like a kettlebell here in a goblet position, you might change your arm angle to either down at their waist level. So like holding the kettlebell here, you could do like a Zercher squat where you're holding the bar here and have them reach versus there. That might change up their position a little bit more versus somebody who's wide and we want to start to work their arms up overhead. So it might be more of like your typical front squat, double kettlebell holds, everything in the front there. So just those little changes there might change up their position. And again, for somebody who you might see who's super like orthotic during their squat, or they're starting to shift out to the side a little more, this might change that. Same thing with deadlift or really anything else that we're doing in there. So same approaches can be done into a half kneeling position. We do a lot of work in tall and half kneeling positions in terms of like some of the dynamic warm-up stuff that we do in terms of bear crawls, incorporating some of this into our bear crawl positioning is a nice option for us too, because you can start to facilitate more of that posterior tilt. And from what I found, at least clinically too, is like start doing it for myself too. The last couple of days, being stiff, stuck at home. I know me working through it, like I feel a little bit better working through it. Definitely like less back discomfort. I don't find again that it creates any long lasting changes, but that during that session of the day, it can make a pretty good improvement. And really kind of translate over to some of these other different things, which I think is really important for all the clients that we have at the gym and for all our athletes. That's it.
Cool. Greg, do you, I know it is sometimes difficult to get people to do them on their own, and you're kind of subscribing to this idea of doing this stuff right before a lift is going to be beneficial to that lift and have them feel better and maybe even carry over a little bit more because you're getting it to stick. If in an ideal world, like if someone did have some dysfunctional breathing and some posture issues, like how often would you want to see them doing this stuff at home? Like, do you give them a specific amount or?
Tell them daily.
Just
I say daily. Most people want to do it daily. But I think the more that you do it, maybe the less you'll have to do, like right before you do a lift.
Right. Yeah. Yeah. It's similar to what we say. It's kind of like you can't overdo it. Like if you have dysfunction in this area, like you're not going to overdo this stuff. So, but it's also like being realistic. If you say, hey, do it 5 times a day, nobody's going to do it because the habit is going to be tough. But if it's
definitely in doing it daily, I mean, even especially right now too, it's like not only is there like the musculoskeletal benefits that you can get from some of these exercises, but just a deep breathing in general is good for all the systems in the body, right? So everybody's stressed and there's a lot of anxiety right now.
Absolutely.
Even facilitating that autonomic nervous system is going to make a huge.
Yeah, I mean, I've noticed like when I'm doing my stuff in the morning, my routine, we talked about it during the morning routine talk. I'm doing this type of breathing, but I'm doing it focused on doing it for a different reason. So it's kind of like, kind of know yourself and know what motivates you. Like if getting your posture and your breathing improved is what's motivating you, great. Let that be the motivator. If it's, de-stressing as a motivator, like the mechanics should be the same. It's really just like maybe just kind of telling yourself in your head as far as what's going to make it part of your everyday habits,
Right. Or the same thing too is like somebody like they just want to get stronger, they want to get bigger. Like they're like, well, you do this, it's going to translate over to your squat.
Right. Yeah. Knowing yourself or knowing the client or patient and what's going to motivate them the most to do it more. Cool.
And then, so I kind of went through that quickly too, in terms of like some of the mechanics of the stuff. If anybody has some questions, I can kind of go into that a little bit.
No, I think it was really good. I think it was deep enough that people could get a sense, of that there are different ways and specific kind of approaches that could be taken depending on which dysfunction you have. And then obviously people, Eileen, you may have something to add, but I know we may have people that watch this later on. They could always reach out to me to get to Greg or get to Greg somehow obviously when everything we're back in the gym, it'll be a lot easier for him to do the assessment. But there's always opportunities to do, video conference calls and things like that as well. I know a lot of people are doing stuff like that. And I know you've offered that up as well throughout this time. So,
And something like this too, it would be relatively easy to do on video conference calls where, you need that manual hands-on treatment right now, but it's something you can do your own, and it's not really hard to assess. Again, it's kind of just like, all right, find your ribs, put your hands there. You'll get a good idea of like what will be the driver of like what's going on for your issues.
Yeah, definitely. Anything for you, Eileen? Do you have any questions?
I'm curious, those braces that people wear to keep their posture, is that beneficial? I mean,
I don't think so. And the reason for that, if I'm going back to here, so most of those braces, they tend to just pull you back, right? And so if I'm like in the second position and I wear a brace that's going to fix my posture and it pulls me back more, Like
Right.
you're playing into whatever issue is already there. So I don't think those really, I don't think those braces like stack you. I think they're just going to pull your shoulders back. And so
Uh-huh.
it could be playing more into like the second picture here. You could be playing into that a little bit more versus this third picture. It might pull your shoulders back, which this person needs, but it's still not stacked. So now their head's forward, shoulders are back. It's kind of awkward. So I
Right.
don't love those just because it's so general where everybody needs something a little bit more specific, I think.
Yeah. So one thing to add on that, and I know like this goes a lot deeper, and I'm sure you could speak to this too, Greg. But what always pops up in my mind when you go to something like that, like a brace or something that's going to kind of force you in a position, is it reminds me of that idea of movement as a behavior, and posture as a behavior. Like there's a reason why people are in the postures that they're in and doing, and it's not only because they're tight. Like there's a deeper psychology there too. So like sometimes the exercises is, we've talked about this in a lot of the these lunch and learns about the exercise. Like we're not just this meat suit walking around with muscles and bones and
Right.
tendons and stuff that can be stretched. Like that's why I love the breathing approach to it, because it's addressing that psychosocial and those other systems of the body that could be contributing to the reason why that person has bad posture and bad breathing.
Yep.
Right.
Exactly.
So we do in the FMS courses, we'll have people do the movement screen when they first walk in. They get their scores. And then when we go through our breathing part of the course, which is usually in day 2, depending on the way it's set up. But in day 2, what we'll do is have everybody go through the breathing exercises, and then we immediately have them rescreen. Probably about 65 to 70% of the people go from in the movement screen, it's a 1 goes to a 2. So whatever their weak link was, whatever they had a 1 on, they just corrected it without any like exercises. They just improved their breathing. So it's like what was driving that dysfunctional movement was probably a lot deeper than just having them do some stretches.
Yeah.
So
people have different holding patterns too. So
yeah,
like there's different postural things that we talk about too. So like not to get too deep here, but there's like people who've had like a history of abuse, things like that. They'll tend to hold their shoulders here. And if you don't address some of those underlying issues, your shoulders are going to stay there. Like no exercise is going to really get out of that until you address some of those issues too. But
absolutely. The thing we always used to say was when I would tell the coaches when we talk about breathing or posture with an athlete, and it's like early in time, the parent always goes, "See, I told you should have had good posture." All this, and I always have to stop them and say, "Listen, it's what you were telling them to do at the dinner table by forcing them into a good position. That probably wasn't going to fix it either. So don't worry, like don't worry about it. We'll work on it from a movement and training perspective." Rather than just forcing somebody to go somewhere. I mean, it's definitely kind of, your body gets used to things and it gets into these habits. And if you try to force it, it's going to fight back. It's not going to snap into what you want it to do for many reasons.
Yeah.
But I think the braces and the things that are kind of artificially putting you in positions, I think that's what comes up for me, is that idea of movement and posture and all this stuff as a behavior rather than just the mechanics of it. Right? So, all right, guys, anything else to add?
No, it was good. Thank you.
This was great, Greg. Thanks so much.
Yeah.
Thanks,
Pleasure.
Greg.
We might make you the resident expert on Thursdays.
I got nothing else going on right now, so I'm in.
Sounds good. All right, guys.
All right,
Thanks
guys.
so
Thank
much.
you.
Yep.
Thanks,
I'll post
Greg.
this in a little bit. Okay.
Okay. Bye.
Bye-bye. See ya.
Bye.